we're talking about fever and sepsis in kids. He's going to give us his take on how we should be managing this. Dr. Stern, could you tell us a little bit about yourself?
For anyone who hasn't met me, I'm Eric. I'm one of the PDR attendings. I came here in the wintertime, so I'm new here. And before that, I was at A&M at Scott and White in Temple, Texas for about 8 or 9 years. And I trained in Philly.
Great. Awesome. Excited to have you here. Thanks again for volunteering to do this. So let's jump into it. What red flags do you look for when you are at the door of a patient with fever?
Well, I feel like a broad question. So the biggest red flag is any fever in a neonate. So a fever under 4 weeks and is an emergency. That patient needs to be seen immediately, and they need to have antibiotics on board. So our target is to get them in within 30 minutes, antibiotics, and then obviously they need to have a full workup. So that's the biggest red flag. Otherwise, under 3 months, it's something that you should pay attention to. Like, you should see the patient, let them sit for a couple hours, probably. Older than that, I don't really care.
Okay.
and there was a question on the slides about from the door. You can't see shit from the door in a 4 week. It doesn't matter what you see unless they're dead already, I guess, but what you see from the door doesn't matter in a neonate.
All right. Appreciate the honesty there. So when you were training, did you use the pediatric assessment triangle? And is that still your structural approach?
So I think that it's super simple, but I think the pediatric assessment triangle is a good way to think about when you see any kid. So there are a couple of things I wanted to talk about with it. The first is appearance, which we kind of already talked about. Like I said, under 4 weeks, I don't really care what they look like. So an infant, like a neonate, they look like a baby until they die. So they're just little blobs, for the first 4 to 6 weeks. They don't do anything. So do you remember when the social smile starts?
Ooh.
So 6 weeks. So the babies don't do anything for the first 6 weeks. And it kind of makes sense when they look at bonding studies, like when do mothers bond with their babies, like prenatally or whatever. Guys tend not to bond with their babies until about 6 weeks. And I don't know if the other two guys here can relate to that or if they would admit it publicly. But, and that's because that's when they start doing stuff, like they start smiling. So you can't tell anything about the appearance of a kid for the first couple of weeks of life. So it doesn't matter. After that, it matters a ton. So you kind of go from one extreme to the other. And everything about pediatric emergency medicine or whatever is about appearance after the first couple of weeks of life. A couple things to remember with appearance as well. Everybody looks miserable when they have a fever. Like I look miserable when I have a fever. So just because a kid looks kind of miserable and they're febrile doesn't necessarily mean anything. It's good to control their fever, like in older kids who are immunized. You're not super necessarily worried about them before you kind of assess whether or not they're puny or whatever. And then with appearance, there's a couple terms that we throw around a lot. The big one is lethargic. What does lethargic mean to you?
Well, I know it's a word that we use with caution in pediatrics because it usually means a kid who is looks worn out, looks less responsive and active than they should.
I mean, that's like me at the end of every shift that I have. I guess I could say I'm lethargic. But to me, lethargic means I can stab you with a needle and you don't care. So have you seen a truly lethargic child? Like, have you had a lethargic baby?
I can't say I have.
It's super alarming. And it's something that you notice right away. And the first time you see it, then you'll never forget it because you'll have a toddler or something lying in a bed and nurses are putting IVs into them and they'll be awake and staring at you or up into space and they don't care. And it's a very abnormal thing for, a 2-year-old who's supposed to be like fighting you and running around to lie there and let you stab them with needles and not give a crap about it. I almost said a bad word. So That's lethargic. The other thing we'll say sometimes is toxic. So to me, toxic means not lethargic, but working on it.
Okay.
So they might fight you a little bit with needles. They're unhappy with you, but you can just get the sense from them that they are really sick. So those are the buzzwords for the appearance thing. For work of breathing, how do you assess work of breathing?
Well, again, I think it's like a gestalt. I'm looking for retractions. I'm looking for just discomfort and then comparing to the vital signs, I guess.
So that's sort of right. So it used to be a gestalt, but now we try to quantify it because it turned out like when you compare what nurses, when they talk about, oh, they're working hard to breathe, and what physicians think of working hard to breathe, there's like really crappy interrelated reliability on a gestalt for work of breathing. So there's a slide I gave y'all on the CRS, the respiratory score that we use. I don't know if you've used it before. I like it. Some people don't. But basically, if you pull up the thingamajig, there's a couple sort of domains, I guess, and you score them as 0, 1, or 2.
Okay.
So, and let me actually pull it up while we chat. But you can see, and so using the CRS, I think it was initially looked at in like asthma patients, and there's other score, like there's a PRAM score or whatever, but I think CRS is pretty widely used in the US now, and it's what we use in Philly. And it actually has pretty good interrelated reliability between nurses and physicians. So in assessing work of breathing, I think it's good to get an initial CRS yourself, but it's okay. Like often I'll have the nurses repeat CRSs, like in wheezing season, on when all the patients, are having trouble breathing, and you can repeat them after treatments or after suctioning or after whatever interventions you do, and kind of get a feel for how they're doing. The other useful thing about the CRS, it helps you decide on disposition. So low CRSs, you can discharge through the moderate range CRS, kind of lets you know, like if you do interventions and they're still wheezing a ton and their CRS is 5, they probably need to be admitted to the hospital. Mm-hmm. And then the CRS 8 or over definitely needs to go to the PICU. So it kind of guide your disposition of the patient. The other thing about work of breathing is you have to look at the patient. So you need to take their shirt off, or at least lift it up to look at them. What's the other thing in America that hides work of breathing?
I'm going to just use context clues and guess obesity.
Yeah. So I always worry in little, I guess, for details or details or whatever you'd say, that they're hiding, respiratory distress underneath their fat. So just have a little bit more suspicion in a fat kid that they might be hiding more retractions that you're not seeing. So that's pretty much my spiel on work of breathing. The other part of the PAT is the circulatory part. Do you see where it says pallor, modeling, and cyanosis? Mm-hmm. Okay. So in a septic adult, how do they look?
I think they're usually like kind of warm and sweaty.
They should be, right? I'm talking about a 90-year-old with an EF of 10%. But in your classic distributive shock, right? So they should be warm and flush. They should actually have a brisk capillary refill. They should not be modeled. What type of shock does pallor, modeling, cyanosis sound like in an adult?
It'd be like a cardiogenic shock.
Exactly. So that's my biggest point with this, is that kids, babies especially, present in septic shock with the physiology of adults in cardiogenic shock. So that is the biggest thing. So you would expect it. Now, this is about 70% of infants with septic shock. So other infants present a mixed picture. And so they may be hyperemic and everything. But the majority of infants present with cold, clammy. What happens to their blood pressure?
Decrease.
Right. There's systolic blood pressure, their diastolic blood pressure, they're both bottom. What happens to their systemic vascular resistance?
Would decrease their SVR.
Right. So they have a low SVR. And that's the problem, right? Because they're pulling everything in their extremities and they're hypoperfused. Mm-hmm. So what do you think the SVR is in an infant who presents cool and moderate and whatever? Goes up, right? Okay. So they have high systemic vascular resistance. What do you think happens to an infant in septic shock with their heart rate?
Increases.
It increases for sure. Okay. Let me ask you about their heart rate. So where do you max out your heart rate before you have an arrhythmia? Like how high can you go?
You could tolerate about 180 maybe. After that, it's pretty much you're going to
220 maybe, right?
220? Okay.
Let's say.
Uh-huh.
I see babies all 200. With a febrile baby, they can go up to 200, 220 max, okay. Right? After that, if you have a higher heart rate than that, you should think they're an SVT. Adults, they can increase their heart rate a lot too, right? And I think I have a slide on this. See, it says adult increased heart rate, maybe up to 160. A neonate or an infant, their resting heart rate is like 120 to 140.
Yeah.
So an adult can double their heart rate in response to whatever physiologic stressor they're having. Infants can't. So, because like we said, anything over above 120 or so, or 220, excuse me, is arrhythmia. And obviously, if you develop arrhythmia, your cardiac output is going to go down.
Mm-hmm.
The other thing to remember about infants who are septic is their contractility. If you do in an adult who is in septic shock and you put an ultrasound probe on their heart, what do you think that happens to their stroke volume, their ejection fraction?
Well, I think initially it rises.
Absolutely, a lot, right? So a healthy adult who is septic from whatever, they should be able to increase their contractility a lot. Babies can, infants can. The major reason is that they have predominantly type 1 collagen in their hearts. As you age, it gets replaced with type 3. And so it allows increased contractility of the heart as you age. But baby hearts are like adult hearts. You can think of them almost as diastolic dysfunction kind of hearts. They're stiff. Their hearts are stiff. And so they're still preload dependent. So you need to give them fluid in the same way that you would give an adult who's septic fluid. But they're not able to increase their stroke volume nearly as much as an adult is. So what happens in infants, the majority of infants in septic shock, they have a rising systemic vascular resistance. That decreases your cardiac output. They're able to increase their heart rate to a set point to try to increase their heart rate. They're not really able to increase their contractility, and their heart becomes stressed, and they actually act very much like they're in cardiogenic shock. So in adults, what's your pressor that you give every adult?
Typically norepinephrine.
Yeah, Levophed. Leave them dead or whatever. Levophed. So in an infant, though, what does Levophed? What physiologic sort of variable does Levophed address that we just talked about?
The SVR, I think, would be the...
Right, exactly, right. So, but if you have an infant who already has an increased systemic vascular resistance, it makes no sense to increase. So, in an adult who's in distributive shock, it makes sense to increase their systemic vascular resistance. It doesn't in an infant who already has a high SVR. So what other sort of vasoactive medications might you think about treating an infant with who presents in septic shock and they're cold and clammy and mottled and their capillary refill is super delayed?
I would think something with some beta effects, maybe.
Okay, yeah. So babies can't recruit their own contractility very well at all, like we talked about, but we can do it for them. So in an infant, very often in an infant who's in severe septic shock, in addition to giving them fluids, we may use agents like milrinone or dobutamine, which you would never use in an adult, right? Because they increase contractility, but they also plummet your systemic vascular resistance. But they're the same agents you would use in an adult who's in cardiogenic shock.
Right.
So very often, if you have a severely shocky baby and you've already volume resuscitated them, and they still have a very delayed capillary refill, you go ahead and give them a bolus and start a milrinone drip, which you would never think about doing in a septic adult for obvious reasons. So it's a little bit different vasoactive medication choice. The other thing that sometimes we'll use is dopamine too, especially in like a mixed picture, where you're not entirely sure and you don't want to bottom out the pressure. You can give them a little dopamine, or even you can use epinephrine often too, because it has both alpha and beta activity. So it increases your SVR, but also increases contractility. So a little bit different pressure choice in infants to think about. And then the last thing I think I wanted to talk about with the circulatory side of the PAP is capillary refill. Where do you check it?
You usually check on the extremity, like the toes, or?
Well, you're wrong. Don't do it. No, you want to. What we care about is central capillary refill in the infants. Because their little fingers and toes, whatever, they get cold. Who cares? We want to know essentially what their capillary refill is. So people will check at the angle of Louis on the chest, or I like, because usually there's 5, morbidly obese nurses, around this, 4 kilogram, and whatever like that. It's kind of hard to get in there. But usually we're by the head. So I like to give them a little dot right there. And so what should a capillary refill kind of be?
Less than 2 seconds, that would be pretty
good. 2 or 3 seconds for sure. Now, there is some pervert who did a study. And I'm sure he was a Nazi. I don't want to actually look, because then I can't use it anymore or whatever. What do you think the capillary refill is of a freshly dead infant? It's about 8 seconds. So I like this pervert study because it allows me to give a number for how close to dead the infant is. So if their capillary refill is 6 seconds, I'm like, shit, they're 2/3 to dead or whatever. Is that the right math? 3/4 to dead? 3/4. I'm very bad at math. Anyway, so yeah, 3/4 to dead. It gives you 75% dead baby, so it kind of gives you an idea of where the end point is with the capillary refill. So about 8 seconds is sort of the median cap refill of a freshly dead baby. And on that happy note, I think I covered most of the PAP stuff.
Cap refill as an index of how close to dead the patient is. I love it.
Exactly. That's exactly
so
right.
Good.
Yeah.
Cool.
I'm sure it was a Nazi, but whatever.
Can I ask a question, Dr. Stern? What age does this septic shock that looks like a cardiogenic shock, what age does it switch to start looking more like an adult?
So usually after infancy, but even older kids sometimes act the same way. The way that you tell how to treat it, I guess, is the important thing, is your clinical gestalt. So things like modeling capillary refill, their blood pressure, if their pulse pressure is narrow or wide, sort of just nothing fancy schmancy. Lactate isn't going to tell you whether they need dobutamine versus Levophed or epinephrine or whatever. But your clinical exam of the infant does, if that makes sense.
Cool. You ready for the next question? Let's talk about stratifying kids with fever. This is also a big topic in kids.
It's an enormous. So it used to be that any infant younger than 3 months with a fever was supposed to get a full septic workup, which is crazy, right? But we don't do that anymore because the burden of disease has changed significantly over the 80s and 90s in that population. And no, sorry. Do you know what changed the burden of disease in the United States in the late 80s through the 90s into the early 2000s?
Is it vaccinations?
Yeah, which ones?
Strep.
So strep pneumoniae is a big one. H flu was the biggest. H flu, right, Armin? So Armin, in your peds residency, how many H flu meningitis cases did you see?
None.
Yeah, honestly, I haven't either. Like, which is in the US, which is amazing, right? It just doesn't happen in the US anymore. That used to be a huge burden. Same thing with epiglottitis. Epiglottitis, obviously caused by it, used to happen all the time. But the immunization and herd immune effects from the H flu vaccine, also Pneumovax, decrease the burden of disease in children enormously. It made kids a lot less fun for us because they don't get sick nearly as often. So anyways, so in the 90s, as this was kind of happening, there were a bunch of decision instruments that were kind of developed to kind of decide, okay, which kids need to have a full septic workup and which kids can have like a partial septic workup. And so for our purposes, a full septic workup would be blood, urine, and spinal fluid cultures, plus minus a chest X-ray. And then a partial septic workup is everything but the spinal tap. And so I think I sent you a slide of like the Philly criteria, the Rochester criteria, all that stuff. So in the 90s, pick a city with a children's hospital and they developed a criteria. But I trained in Philly, so I used the Philly criteria, or at least I think about it. And so the Philly criteria, basically, if you didn't have an elevated white count, if you didn't have an increased band to neutrophil ratio, your urine was clean, and the Philly criteria had a chest X-ray, your sort of pretest probability or whatever for having meningitis was low enough that it was felt that you could safely discharge the patient. And so we don't use those criteria in the way that they were initially developed anymore because life has moved on, but I still find them useful to think about in older infants. So under 4 weeks, obviously we said that's like emergent, and they need to come in and get blood, urine, spinal fluid cultures, get antibiotics rapidly. Over 4 weeks though, kind of all bets are off. Even when I was in training, sort of that 30 or 28 day to 60 day area, it was kind of uncertain, I think. And so sometimes if I have a kid who I'm, maybe they're 35 days or something, and I'm a little bit worried about them, I'll still refer back to thinking about Philly criteria in evaluating them. So doing sort of blood work, blood culture, urine culture. But if their white count isn't elevated, if they don't have a lot of bands, and if the urine is clean, feeling more comfortable saying, okay, this kid is probably just fine. They can go home or whatnot. So for me, that's the big sort of restratification is the sort of under 4 weeks, where you kind of, at this point in time, we still do everything. And then over 4 weeks to about 60 days, and still being a little bit nervous, maybe. And then after 60 days, I think that at this point in time in the United States, you can treat the infant, the same, 3-month-old or 2.5-month-old the same as an 8-month-old. I mean, what do you think about them?
Yeah, I totally agree. I think the 1 month is for sure he basically wins himself the LP. And what you were mentioning also about the IT ratio, something that's very important, just in case y'all do. So you get the bands, okay, and it's over segments plus bands. And you're going to want to know if it's like 0.2 or above. If there's 0.2 or above, then that means that you're more than likely having kind of like a left shift, right? So there's an active infection going on, and that's going to kind of gear you towards, working them up a little bit more. So I think that's a very important point you brought up there.
Awesome.
I have a question about those criteria.
Yeah.
So obviously they can really help guide your thinking, the age 30 to 60, make a decision. If you, for some reason, you use those criteria and you end up sending a kid home but you say, per Rochester criteria, he seems safe for discharge, and then something ended up happening, God forbid. Are those criteria like validated enough that they'd like hold up in court that you practice the standard of care and it was just a bad outcome?
Yeah, and the Philly criteria in Rochester, they have been around and repeatedly validated since like the mid 90s, I think, at this point, maybe a little bit later, but around that time period. So they're extremely like well validated, accepted, and if you document just your reasoning, bad things happen no matter what we do, unfortunately, and it's a whole philosophical thing. But at some point, you just have to decide how much risk you're going to assume versus are you going to do a spinal tap, on a well-appearing 58-day-old baby, just because you're nervous. And spinal taps are well tolerated, but obviously, especially for the family, parents hate spinal taps. Babies probably do too, but they just can't tell us.
And now with the rise of the respiratory biofire panel, Dr. Stern, how, so if it comes out positive, so let's say para-influenza, right? How much will that gear you into not doing an NLP in a, 1 month old or 2 month old?
This is probably something we can fight about because I think probably the hospitalists, maybe, I don't know what they're doing up there, but the PD hospitalists, but I could give two shits about a respiratory biofire. How many kids with like urosepsis or something, infants, have you seen that also have a cold?
A good amount, yeah.
A ton. So I am reassured, not one iota, by a respiratory biofire.
Okay.
There is now, and I'm looking forward to seeing what happens with it. So there's a blood biofire now. And I'm very interested to see it looked at in neutropenic fever kids and maybe eventually in neonatal fever to see if that's something that may be useful. But a respiratory biofire, I don't care. How many kids with COVID also have appendicitis? I've had like 5. You know what I mean?
Yes. Yeah.
I'm done.
Cool. Good stuff. All right. Well, we've talked on a little bit about risk stratification. That's a huge topic. We could do an entire session on that probably with all the controversy that goes around it. Let's go to a really simple question and ask about whether the number of the fever matters. In other words, does it matter if they're 38 Celsius versus 39.5?
So under 4 weeks, anything 100.4 or greater or whatever is going to get worked up. After 4 weeks, it doesn't matter a ton, but it can matter in some circumstances. I think at some point I sent you the AAP UTI probability table. And for example, in that table, the height of fever has a positive correlation with the chance of the infant having a urinary tract infection. So there are a couple little criteria or style points or wherever where fever height kind of matters a little bit.
And that's over 39 Celsius in those guys.
That's right. That's right. 13, yeah. And I mean, just common sense, a kid who has a 40-degree fever, very, very well may just have a cold, but it definitely makes you think twice if you have some other reason to suspect that, sepsis or whatever. But like I said, in the context of some decision roles, the height of fever after 4 weeks matters. Under 4 weeks, it doesn't matter one bit.
Okay.
Now, with that being said, Dr. Stern, what, like in our culture, mom's going to come in and say, ay, mi hijo se sentía calientito, right? He felt warm. So that's a fear. But he comes in and your triage vital signs are not showing the fever and no antipyretics were given. How do you go about that? Do you still work them up?
Under 4 weeks? If the mother just said that they felt warm, but there's no documented fever and and there's no fever in the ER, I might watch them for a little bit and recheck their temperature and whatnot, but I don't necessarily work that up automatically. Now, if the mother says that they check the temperature at home, no matter how she checked it, whether it was with the ray gun or the sticky one or whatever ridiculous, and it was high enough to care about, then they get a full workup, unfortunately, if they're under 4 weeks.
So that then leads me to the question about kids who have gotten acetaminophen. Does that and now are afebrile? Is that the same kind of thing? If they, so they've gotten, you just watch them for a while and then stratify based on age.
Yeah, for sure.
Okay.
Age, exactly. So under 4 weeks, if they had an actual fever and they got Tylenol or whatever, they unfortunately have bought themselves a complete workup.
Okay.
And so just for Tylenol and Motrin, so Tylenol we can give to anybody, any age is fine. Ibuprofen usually will start after 6 months. So in the ER, you'll lose a couple style points if you give Motrin to a 3-month-old.
Okay, so then let's get into the controversy about LPs. You've touched on it a little bit already. That's part of your quote unquote full sepsis workup. However, I think on the adult side, we're using LPs less often. This has come up a lot
I'm so jealous of you people. I'm jealous because when I was in residency, the stuff hadn't, or at least in Philly, it hadn't come out or they didn't trust it or whatever. I had to do so many spinal taps on headaches for subarachnoid hemorrhage. You have no idea. I feel like I did a pelvic and a spinal tap on half of the population of Philadelphia in my time. Everyone got a spinal tap. It was ridiculous. Anyway, now you're getting so spoiled. You don't have to tap anybody anymore. Lucky bums.
Well, lucky patients too, probably.
Anyway, so I guess that means it's even more important that you guys get good practice doing LPs. And so with infants, the biggest thing is just getting comfortable with your landmarks and having someone who is really good at hold the baby. That's probably number one. Because usually they're not morbidly obese yet. Maybe by 3 months.
Okay, so let's talk about urine a little bit more. You mentioned that as a source of fever. We've talked about a couple sources of fever here, but this is a particularly common one. Who needs to get urine, and is it everybody? And should we be getting caths, and who needs caths to get the urine?
Yeah, only caths and non-potty trained kids. So usually 2 and under, but you can ask the parents if they're potty trained or not. But if they're not potty trained, they have to have a cath urine specimen. It's rare that you need a urine badly enough to do a suprapubic tap, but that's the other option to get a decent sample and in a baby or whatever. Bags are essentially useless, really. If I see someone putting a bag on a 3-week-old, I'm probably going to poke you in the eyeballs because it's unless you're doing a drug screen. Other than that, get out of here. And then I think I gave you the AAP UTI thing, which I actually find pretty useful. In my day-to-day practice, at least as a way to think about which kids I want to get a urine on and which kids I don't. And I won't belabor it because you can look at it yourself. But I do find that in kids over 4 to 4 weeks to 60 days and older infants, that kind of is a decent guide to help you decide whether or not to get a urine on them in the ER. The other thing you can always tell parents if they have a high fever or whatever, but you're not there yet, is, they can get it done in their doctor's office if the fever persists for another day or two. Most older infants are, they're going to be okay with the UTI for an extra day or two before they, famous last words, but most of the time they'll be okay. So that's the other thing. You can always talk if parents are super freaking out about the cats, which happens occasionally, is kind of a watchful waiting approach, and just document that you recommended, a urine sample in the ER and that parents didn't want ones, but you came to agreement, that if they're still febrile in a day or two, they're going to go to their doctor and have one done there. So the other thing on sources of fever I just wanted to cover is just to go over pathogens. So in a neonate with fever, so let's say you have a 1-week-old with a fever, what bugs are you worried about?
Listeria is one of them.
I know. How many meningitis have you seen?
No, I haven't seen any.
No, neither have I. But yes, we worry about it all the time. Yes, so we. It's the stupidest thing, but yeah. So listeria. What else? Low-hanging fruit there, dude. What else?
GBS.
Yeah, GBS for sure. This is a huge one. So when does GBS? Go ahead. I'm sorry.
Strep and staph. We were about those as well.
Yeah, strep pneumoniae for sure is a common cause of meningitis. Better after vaccination, like we talked about. GBS for sure is huge in the neonate. So GBS disease is interesting. So GBS used to be a disease back when people actually stayed in the hospital for a couple of days after they were born. It used to be a disease of like the nursery. They would be in the nursery at 2 days or 3 days and get a fever. I would say that now we often see later GBS. So GBS always had kind of a early presentation and late presentation. I feel like most of the time now when we see GBS, it's like late and later presentation of GBS. And I think it's from treatment. So treatment does decrease the incidence. Treating the mom will decrease the incidence of the GBS disease, but it also seems to delay the presentation of it. So it's common to see an 8-day, 9-day-old infant now with GBS meningitis. One time we had a 3-month-old who died from GBS meningitis, which I have to believe they somehow got re-exposed to it, but maybe they didn't. I don't know where the GBS hung out for 3 months, but it was hanging out somewhere, I guess. Okay, so we talked about GBS. We talked about H flu earlier.
Can I actually ask a question about GBS? I'm sorry to interrupt. If the mom was positive for GBS, but it was treated, does that change your decision making? Maybe if the kid's 40 days, 50 days or something, or that's too late, you think? So
after 4 weeks, it doesn't automatically, it still won't automatically buy you. I might think about doing a partial sepsis on them and making sure they don't have a white count and they don't have a lot of band or whatever. But just a treated GBS mother after 28 days by itself isn't going to buy you a spinal tap if you see me. And then, like I said, under 28 days, if you have a fever, you're going to get one anyway. So E. coli is another huge pathogen in infants. And then there's one other bug that you should think about, especially in the first 2 weeks of life.
If there was like active lesions or any, herpes could be one.
Herpes is huge. And, you don't have to have active lesions to get HSV. I mean, it helps, but you don't have to. So in the first 2 weeks, if I'm at all worried about it, or is it something good to think about? And so herpes disease in infants presents in 4 ways, which are good to think about. Do you remember the four flavors of herpes? No, you're clean. No, so mucocutaneous, right? So eyes and skin and all of that business. And meningitis, obviously, right? Or herpes encephalitis or whatever. Herpes also really likes the lungs. So if you think about Chickenpox, which is a herpes virus, obviously, back in the day when it used to kill people, it frequently did so by giving them pneumonia. Same thing with infants. So infants with raging viral pneumonia, and there are 2 weeks or under, just think herpes, herpes, herpes. And the fourth one is what we call disseminated herpes. And so it likes to eat your bone marrow and your liver. So if you have a kid, like a 1 week old or 2 week old, and they have a fever and you do a septic workup on them, and they have thrombocytopenia, or their LFTs are bumped, that just screams herpes. So for those infants, you need to cover them in addition to antibiotics immediately with acyclovir. If you all think about, because herpes, it kills babies so quickly, and eats their brains, and if it doesn't kill them, it makes them, damaged forever. So that's acyclovir. And then what other antibiotic choice do you use under 4 weeks to cover the other bugs we talked about?
Gent or cephalosporin.
Yeah, so AMP and Gent, or AMP and cefotaxime are usually the two regimens that you think about most. So AMP and Gent, or AMP and clavurin. And then at what age do you think about switching over to using something like ceftriaxone?
So actually, after the month, because ceftriaxone is the one that displaces the bilirubin from the sort of conjugated into unconjugated.
Right. So usually after a month or two, then you can think about giving ceftriaxone, and people love to give ceftriaxone and I feel like we give ceftriaxone, like you just sprinkle a baby with ceftriaxone, they magically get better. But just remember to be careful with the ceftriaxone under a month or so, because you don't want to give them kernicterus.
We haven't talked about vancomycin yet.
That's because we don't use it that much. Under 4 weeks, I almost never use vancomycin. We just haven't really seen a ton of MRSA infections in that age group. Older kids with meningitis, I will definitely use vancomycin for them, or if they're super shocky or septic or whatever. But most infants don't need vancomycin. And even for, let's say, like an infant, let's say a 6-month-old who has a big abscess or something like that, most of the time we actually will still start with clindamycin for them, because just by draining it and it's probably enough, honestly, by itself. But we still, if they're febrile and they're sick and they need antibiotics, even though we see MRSA in that age group all the time, clindamycin covers it probably, depending on where you are, maybe 80 or 90% of the time. And so usually we don't jump right off the bat to vancomycin. I mean, there's nothing wrong with using vancomycin, but it's just not as commonly. I know you give it out like water next door.
Do you routinely give acyclovir for your infants that are still undifferentiated?
If they're under 2 weeks, and I'm at all worried about it. So the mom has a history, their LFTs are bumped, it sounds like they have pneumonia. Or honestly, if they're not just febrile, but they're sick, like their vital signs are abnormal, I give it. Because what's the harm of giving a single dose? If they want to stop it upstairs, they can stop it upstairs. It's one dose of acyclovir hasn't never done anybody, I don't think. Much had happened in minute shift, but.
So we've talked about antibiotics. I think we got a lot of nice information there. Let's talk about fluids, the other part of this early sepsis workup. I have kind of a textbook approach: bolus, 20 cc's per kg, 4-2-1 for maintenance fluids as needed. Is that adequate, or should we have a more nuanced approach?
I'll repeat boluses maybe 3 times. If I'm having to bolus 3 times to an infant, I'm probably also going to be starting vasoactive medication on them, like we talked about earlier, either epinephrine, or if the picture is right, maybe milrinone, or both. sometimes it's nice to start with a little epi and see what that does. And then the epi, like I said, increases contractility, but obviously also it has alpha effects. So you have a floor to your systemic vascular resistance, so that if you need to add milrinone or whatever, you know that you're not going to excessively vasodilate the patient. So it's nice sometimes to use a low-level epi drip to kind of give yourself a bottom, and then add on milrinone or dobutamine if you have to. The other thing was fluids. So for maintenance fluids, we don't routinely add potassium usually to infants and their maintenance fluids unless there's a reason to. So for maintenance, usually we'll use the quarter NS in neonates, or the half NS in babies and older kids. And then the other thing about fluids is every year in most children's hospitals, somebody dies or almost dies on the floor in the winter because they come in and they have a runny nose and they have bronchiolitis, you think, and they're a little bit dry. You get them some oxygen, you give them a bolus, maybe they get another bolus, they kind of get a little bit better, they go up to the floor, and then they code. And the reason is because of viral myocarditis. So it happens very commonly. Do you know, Richard, in infants, how congestive heart failure presents?
I do know it's very non-specific.
They look like it happens in the winter because they got a virus in the winter, and they look like bronchiolitis. You're right.
Okay.
But the thing about, how do you, in adults, like, where do you look for volume overload in adults?
Well, you look, on exam, we're looking for JVP, we're looking in the lower extremities, and then on x-ray, we're looking for pulmonary edema. We can use an echo for ejection fraction and so on.
Right. So kids, they do things a little differently with volume overload. So the first thing that happens to them is they drop their liver. They get hepatomegaly from it. And so in the wintertime, if you're repeatedly bolusing a bronchiolytic, it's a good idea to go and, when you first feed them, kind of get an idea where their liver edge is. And if you had to bolus them a couple times, reassess where their liver is. Because if their liver has dropped, you should be concerned that this baby is becoming volume overloaded and maybe they have myocarditis.
And when you say the liver has dropped, you mean the liver edge is palpably enlarged, like palpably lower in the belly.
Right, exactly. Palpably lower in the belly. And RALs and all that business, first of all, they're probably acting like they have bronchiolitis anyway, and who can tell what is bronchiolitis and what is volume overload. And pulmonary edema shows up very late as well in infants, so you would not necessarily see on chest x-ray, and they don't get dependent edema usually. So that's the other sort of pearl with fluids, is to pay attention in a kid who you're having to repeatedly bolus where their liver edge is.
Good stuff. All right. Well, I'm kind of wrapping up the questions that I have. If either of you want to jump in and add anything.
If you have a kiddo with a fever and then you find what you think is UTI, is that the end of the workup, or do you ever consider other things, like if there's another co-infection or something?
So under 4 weeks, you can't blame anything on the urine. I mean, it obviously needs to be treated, but they still need a spinal tap. Unfortunately, they very well could have E. coli everywhere in their blood, in their urine, in their spinal fluid. And in an infant that you're worried about for other reasons, the urine should not falsely reassure you. There was a case here in El Paso this winter. It was a strange case. There was an infant, a 5-month-old, who presented. The mother said that they weren't moving their leg right. And I went to go see them, and It was a 5-month-old. It's hard to tell. I looked at them. I'm like, well, maybe they're holding their leg a little bit funny, but I have to trust what the mother says. You know what I mean? And then I just kind of noticed, like, they moved their head, but the baby did not seem to want to. You know what I mean? And so and they had a high fever, and I thought, this is very strange. And the urine in this infant was infected. However, I did a spinal tap. And they ended up growing out Neisseria meningitidis from their spinal fluid, from their blood, from their urine, and from their hip. So a UTI by itself in the infant doesn't necessarily mean bupkis, unfortunately. If you have other reasons for it, you know what I mean? Not over 4 weeks, not every UTI needs to have a spinal.
Right. But it's just like the biofire you're talking about. It just doesn't give you good quality information.
Exactly. That's exactly right.
So one other question that I was meaning to ask a little earlier when we were talking about diagnostic workup was which patients need chest x-ray?
Now that's a controversy. As you can see in the Philly and the Racha, some of the criteria have a chest x-ray included and some of them don't. Do neonates tend to get lobar pneumonia?
No,
they don't.
No.
Yeah, right. Not at all. If they have pneumonia, it's usually it's probably herpes, honestly. There is some utility to think about a chest x-ray in a neonate who's coming in and they're febrile and shocky and everything, but it's not for infection. Anybody? For congenital heart disease. Exactly. Because, like we said, infants who are septic and sick present like cardiogenic shock. Well, cardiogenic shock, also obviously acts like cardiogenic shock in babies. And so it can be sometimes hard to distinguish. So if you shoot a chest x-ray and you see massive cardiomegaly, you got a clue. Especially you get an infant coming in after a couple of days to a week, when their ductus is closing and it's at the same time period, but maybe they had a little fever and they don't look great, they're mottled. It can sometimes be, you can get fooled occasionally by the closing ductus and just assuming that it's the baby is cold and mottled, whatever, because they're septic, but really, they have a closing ductus with we had a case here. I actually really enjoy the amount of heart disease we get to see here in El Paso because of Mexico. Because in the U.S., like most congenital heart disease, it's kind of sad because most of it is kind of diagnosed upstairs, even before the baby is born or whatever. But here, there's a ton of really great congenital heart disease that presents to the ER, and it's a lot of fun. We had an infant code who did well this winter or spring that was 13 days old and had a closing ductus. It actually closed by the time they came to us because they had an undiagnosed coarct. It was a really, in the rest of the U.S., you're probably not likely to see nearly as much undiagnosed congenital heart disease as you do here.
So I have a question. It's just kind of going down. You mentioned, okay, we give fluids, maybe the 20 cc's doesn't respond, 20 cc's doesn't respond, and you start thinking of the cardiomyopathy, right? Myocarditis. So at what point, and maybe you start a pressor, okay? At what point do you say, okay, this, and I know you said hepatomegaly, but this might be myocarditis, or this could be like fluid or shock due to adrenal insufficiency?
It's difficult. Honestly, and you can volume overload a healthy kid. They're not going to be they're sick, but otherwise healthy kid too. It can be very difficult sometimes to distinguish. So I'm glad you brought up congenital adrenal hyperplasia, because that's another thing that is a sepsis mimic in infants to think about. So a couple weeks old, maybe their scrotum is abnormally pigmented. Infant who came in vomiting, whatever, you should definitely think about congenital adrenal hyperplasia and see what their electrolytes look like, because like those infants obviously need steroids. The other thing to think about in the febrile infant who may need steroids is meningitis, right? Because you can get a adrenal infarct, obviously from it. So, so there are definitely times to think about steroids in infants who you think are septic. Was that helpful? Or?
That was very good.
Got another one too, since we just mentioned pressors. For adults, we use blood pressure to help us decide when to start them, but we haven't talked about blood pressure at all. Do we use blood pressure to, factor into whether we start pressors, or is it more like the other signs and symptoms?
So absolutely. So obviously, if they're remember that normal blood pressure in infants we use like 5th percentile basically blood pressure. So in a newborn, it's like 60. At a year, it's 70. And then at 70 plus 2 times the age after that for their systolic blood pressure. So if you have an infant who is hypotensive, obviously in that infant, you're going to start something like epinephrine drip first. Now, in terms of starting something like milrinone, like I said, you may need to start epi first to give yourself a floor, especially if they're becoming hypotensive. But if they're sometimes, honestly, septic infants who are shocky actually are hypertensive, which is kind of weird and for an adult to do that. But if you think that they have if their SVR is too high and their blood pressure is okay, you can definitely go ahead and start something like the butamine or milrinone. I use milrinone more often than the butamine from like personal preference, and it's a little bit easier to manage the drip with it. And I feel like I've had less experience with it bottoming out blood pressures, honestly, than the butamine. But the other thing to think about is their pulse pressure. So like they may not be hypotensive, but if they have a narrow pulse pressure in their cold and clammy and mottled, that's another indicator that that they're kind of acting like cold shock. The other thing that I look at with blood pressure in infants is widening pulse pressure if they're going to act more distributive. So you may have an infant in your ER, and you notice over a couple hours that they're with you that their pulse pressure is widening. And hypotension is an extremely late finding in infants. I usually say if the infant is hypotensive because of sepsis or whatever, the next blood pressure is probably going to be 0. It is a very, very late finding. And I think we touched on it, but we have a saying that babies fall off a cliff. And so and it has to do with the physiology that we already talked about, So basically, how does a baby increase their cardiac output? They increase it by increasing their heart rate. They can't increase their contractility. Adults can do both, but a neonate can't really increase their contractility. So in an adult, initially, they're tachycardic and then maybe a little hypotensive and more hypotensive, and you can kind of see them going down. An infant, a neonate, they just look like a blob. They just look like a neonate who's tachycardic, and they just sit there and they're tachycardic and they stay there and tachycardic and then they die. That's just how it works because, they have only one way to compensate themselves. They're not going to tell you very early on, with progressively lowering blood pressure or anything like that. If they're hypotensive in a neonate, like I said, they're probably going to code on you in a minute.
Right. So it's not unreasonable to start pressors if they're not really responding to fluids, their cap refill is not improving, their tachycardia is not improving. To actually start a pressor, you don't have to wait for them to become hypotensive. Correct?
No, do not. Yeah, don't do that. That's exactly right.
Awesome. And I'm not going to lie, all the different pressors are a little bit intimidating. So I imagine myself in a community hospital, a few hours from a children's center that I have to send somebody to. If I had a kid that I thought needed pressors, would you say that epi is just a safe thing to start with?
Yes.
To get them to the big center?
Yeah. I think an epi drip is probably your best bet. And the other thing that's nice about epi and you're working in BFE or whatever is that it's super easy to mix a dirty epi drip. Yeah. Which you worked in, I've probably done before.
Yeah, good.
Stop. Sorry.
Well, I think I don't have any more questions at this point. There's a lot to absorb. This has been a great conversation. I'm going to watch this again and make sure I get every bit out of it. Are there any other sources you wanted to, resources you wanted to highlight? I think we've covered pretty much everything.
I think that everybody should have a Harriet Lane. Yeah, I love the Harriet Lane. People go either way on it. Armin, do you like Harriet Lane or do you hate it?
It's really good, and especially if you just want to look up something, you have really good tables. So, yeah.
And the formulary in the back of Harriet Lane for dosing and everything can't be beat.
Let's wrap it up. Thank you again, and look forward to doing more of these in the future.
Yeah, for sure. Thanks, Victor.
Hey guys, that was a lot of great information from Dr. Stern. First thing he really wanted to get across was that if an infant less than 30 days come into your emergency department with a fever, that's a medical emergency and you should treat it as such. Resuscitate, give them fluids, give them antibiotics, get their workup going, and get them dispositioned. It's a medical emergency, we should treat it as such. The next thing we moved on to is the pediatric assessment triangle. A for appearance, B for breathing, C for circulation. He did remind us, though, that in an infant less than 30 days, they're more or less blobs and they don't really do much. So the appearance isn't going to give us a lot of information. Use the fact that they're less than 30 days, use the fact that they have a fever to treat them as a medical emergency. We moved on to B. He recommends, instead of using your gestalt of how well this kiddo is doing, use something called the CRS, the Clinical Respiratory Score. What that is an objective scoring system that gives us a number for how much respiratory distress our kid is in. This is very useful for prognostication, for disposition, and also for seeing how your treatments are doing. We next moved into C, circulation. Now, we talked in detail about the pathophysiology of infant sepsis, infant shock. The biggest point I learned from this is that an infant with shock does not look like an adult with septic shock. Septic shock in adult, they're going to be warm, flush, sweaty. In an infant, when they're in septic shock, due to their pathophysiology, they're actually going to be cool and clammy. They actually look like they're in cardiogenic shock, not a septic shock. Very important point to remember. When evaluating the shock, he recommended checking for a central cap refill, not peripheral. So do it right at the angle of Louis, maybe right on their forehead. Less than 2 is normal. 8 means they're probably not going to be living long. So 2 to 8, kind of see where your kid's doing based on that time frame of their cap refill. Other things that we've discussed were UTIs, when to get a cath, when not to, how to get a cath. He does not recommend using bags. We talked a little bit about how to get an LP, position the patient really well. That's really going to give you a lot of good information. We talked about risk stratification. If the kiddo is less than 30 days and they have a fever, full court press. If they're over 30 days, especially in that 30 to 60 time frame, he recommends using a scoring system such as the Rochester or Philadelphia scoring system. These systems, they collect a lot of data from lab values and vital signs, and they're going to give us some recommendations for how aggressive should we be when it comes to lumbar punctures, antibiotics, disposition, that sort of thing. 30 to 60 days, these scoring systems have been validated, so go ahead and integrate those into your practice as well as into your paperwork to justify why you did what you did. We talked about the bugs that are commonly seen and commonly treated in infant sepsis. Don't forget GBS is a big one, especially in the young kids less than 2. E. coli is a big one. There's less common ones, Listeria. But the big one he wanted to talk about a little bit was HSV. Don't forget, that is a virus that can cause all sorts of damage to young infants. So when you're giving your antibiotics, he recommends AMP-Gent or AMP and cephalosporin. Don't forget to consider acyclovir when you're giving that. We also talked briefly about the whole Rocephin thing. Don't start it in a young infant. Wait till they get a little bit older, probably over 60 days before you're going to start Rocephin. Finally, we talked about fluid resuscitation. 20 cc's per kg is reasonable to give. You can give that up to 3 times. But he said that you're evaluating the patient and whether they're responding to it. It's okay to start a pressor before that. We went into pretty good detail about the different pressors that you can use. He likes one called milrinone. This is due to the infant's increased systemic vascular resistance. I know a lot of us may not be comfortable with milrinone if we're not trained in peds or cardiology. So we did ask him, would it be reasonable to start an EpiDrip while you're transferring your patient from your small community hospital to a larger center? And he said that's a totally reasonable choice. The final thing to consider is that if you're giving your kiddo a bunch of fluid, sometimes the kid may actually be in cardiogenic shock and you're thinking it's a septic type thing. And so they can become a little fluid overloaded. Fluid overloaded infants do not present the same way that a fluid overloaded adult would. They don't get JVD, they don't get RALS, they don't get pedal edema. Plus, it's difficult to assess these type of things in a kiddo anyways. He says the thing to really look for is hepatomegaly. So serial abdominal exams and feeling that liver edge and see if the liver is actually getting bigger. That can really give you good information about whether your kiddo is becoming fluid overloaded or not. I think that's about it. Thanks a lot.